I think interstitial lung disease has been described, or pneumonitis has been described with many agents, from cytotoxic chemotherapy to other antibody drug conjugates to targeted therapies and oral tyrosine kinase inhibitors, as well as CDK4/6 inhibitors. So yes, I've had and treated patients for ILD who were receiving other therapy. Thankfully, it is rare. And I would say that it is important to consider the risk-benefit balance of the stage and advanced treatment that a patient may have had, the benefit they may be deriving from drug, and the potential risk of an adverse event, and have those risk-benefit balance conversations with our patients. The literature has shown that there are particular patient factors that might place them at higher risk for developing ILD. And those include having some underlying interstitial lung disease to begin with at baseline. Also, patients who are smokers or previous smokers, or who have a poor performance status. There's concern of any increased potential risk of interstitial lung disease. There has been some description that patients over the age of 60 or patients of Japanese or African American descent may also have a higher risk of interstitial lung disease with the use of trastuzumab deruxtecan. I think men have been described as having a slightly higher risk of ILD. This drug has been looked at in other cancers besides HER2-positive breast cancer. And lastly, having multiple prior lines of chemotherapy and really being in a heavily pretreated population, much as those that were treated in DESTINY-Breast01, seem to predispose to or have a higher risk of ILD. Back in 2019, the FDA came out with a safety announcement describing a risk of pneumonitis associated with the CDK4/6 inhibitors. And, I think at the time, and even to today, I balance that information, that very real safety concern, with the efficacy and the benefits that we've seen from this class of medications. They have really dramatically changed the advantages that we're seeing from endocrine therapy in women with ER-positive or hormone receptor-positive metastatic breast cancer in the first-line setting and beyond. And so I think that having an awareness of pneumonitis is important. It has not stopped me from using CDK4/6 inhibitors by any means, because I think that our patients derive greater benefit than that potential risk. I have had patients experience pneumonitis, and I have held the CDK4/6 inhibitor. I have had the help of my pulmonologists. We have used steroid tapers and really mitigated any other potentiating risks. And in a couple of cases, I have been able to restart and reintroduce the CDK4/6 inhibitor. So I think it is an adverse event we need to be aware of. We need to have a high awareness of it so that we can withhold the provoking agent, manage those symptoms accordingly, and then make a joint shared decision around the risk-benefit balance of restarting the drug. I have thankfully been able to resume the drug, often with good management. Interstitial lung disease can really present across a gamut of symptoms. Sort of at the extreme, patients can be quite dyspneic with an exercise tolerance reduction. They can develop dry cough. They can have fevers from the underlying sort of inflammation in the lung disease. And so that would be at the extremes. At really the incidental asymptomatic findings, in my experience, I've seen ground glass opacities appear on routine imaging in patients that were entirely asymptomatic, which ultimately turned out to be a drug-related effect of the cytotoxic leading to ILD. And so I think we need to be open to and recognize that ILD can present itself in a wide variety of ways. I think that as medical oncologists, we are increasingly finding ourselves with a knowledge gap of how to best manage some of the new adverse events that are appearing as a result of our novel, highly effective cytotoxic therapies. So we've become cardio-oncologists in managing some of the heart-related risks associated with our treatments. We've needed to become endocrinologists a bit with some of the hyperglycemia issues with some of our great new drugs. And I think that now recognizing the pulmonary toxicity that can come from these agents is a newer area to us to really focus on and improve our skill set. So I think there's an unmet need for additional education in this space. It would be wonderful to be able to have an increased experience in the published literature to help guide this management. And events like this and educational opportunities like this, I think, are helpful for all of us in just learning more about how to recognize ILD, how to react quickly for the benefit of our patients, which often includes holding the drug, getting the help of our pulmonologist, instituting steroids early, and tapering them very, very slowly.